afternoon. Welcome to In the Trenches. I'm going to talk about nephrotic syndrome and possibly nephritic syndrome at the request of my student Julia Milligan. Nephrotic syndrome. So this is a chronic issue. It's not acute. And you need nephrotic range proteinuria. It's either greater than 3 grams per 24 hours. Some cutoffs use 3.5, but assume nephrotic range proteinuria is 3 grams. You have hypoalbuminemia, edema, and hyperlipidemia. Okay, so you're putting out protein, you're gonna have low albumin. And with the low albumin, you're gonna have abnormal Starling forces and you're gonna have edema. And what's interesting, these people wake up and they could have facial edema and periorbital edema. And as they stand up during the day, it'll gravitate downward if they're upright. And you have a patient who has edema and you don't know why they have it, you at least have to consider nephrotic syndrome. It's usually not due to that, but it needs to be considered. And you can get a spot urine creatinine ratio as compared to 24-hour urine collection. So that's defining this. Now, what type of problems they could get into? They could get progression. Sometimes they can have normal renal function. They could have chronic kidney disease. Hyperlipidemia, the mechanism of this is you have a low albumin, turns on synthetic pathways in the liver for albumin, and you also produce more VLDL cholesterol. This goes to triglycerides and cholesterol. And people with chronic nephrotic syndrome need to be on statins. They're at risk for atherosclerotic vascular events. The other thing is, this is a secondary thrombophilic state. So they're putting the anticoagulant, antithrombin 3, which is now called antithrombin, in the urine. And they also have synthesis of other clotting factors, which are increased. And these people could be predisposed to VTE, so you can get it on the venous and the arterial side. They're also putting vitamin D in the urine. They could have low vitamin D, and they could have osteoporosis. And they're also putting immunoglobulins in the urine, and they could have abnormal humoral immunity. They need pneumovax. Somebody with nephrotic syndrome, you have to worry about pneumococcus and other encapsulated organisms, theoretically meningococcus also. That's the problem. Now, what about the causes of nephrotic syndrome? Okay, you really get this by a kidney biopsy. So you can have something called minimal change disease, or lipoid nephrosis, membranous, membranoproliferative, or focal segmental glomerular sclerosis. These are the things you could see in biopsy. Now, you could also see this with secondary diseases. And the diseases you could see, nephrotics, you could see it with amyloid, okay? Not usually myeloma, unless it's, but you see it with amyloid L. And you can see it with diabetes, you can see it with lupus. I'm going to talk about some of these. So you can see nephrotic syndrome with systemic diseases also. But on the biopsy, lipoid nephrosis, usually idiopathic, more common in children, and that's the best prognosis. In adults, the pearl here could be associated with Hodgkin's lymphoma. And interestingly, if the Hodgkin's relapses, it could relapse as nephrotic syndrome. This was also reported with non-steroidals, more in the 1980s when they used other non-steroidals like Nalpan. Okay, membranous could be idiopathic. And really the test for this, and this is the most common cause of idiopathic nephrotic syndrome in Caucasians, you get an antiphospholipase A2 antibody. Okay. You could also see this with malignancy. It could be a paraneoplastic phenomenon. See it with adenocarcinomas of the GI tract. But you can see it with malignancy, and sometimes you have to at least consider that. You could also see this with lupus. And you could see it with hepatitis B. Now, membranoproliferative, the thinking of this has changed. And, this is usually not idiopathic. And the strongest association you have is with hep C. And this could cause nephrotic and nephritic syndrome. And it could also be associated with lupus. These are the two things. It could also be due to abnormal alternative complement pathway. I'm not going into detail in this. Okay, here you have antibodies to the kidneys, and this involves complement. Focal segmental glomerulosclerosis, most common in African Americans. It could be idiopathic. You could see this with IV drug addicts. This was the nephrotic syndrome associated with HIV. Here, the nephrons, they were ballooned. They had a different appearance. You could also see this with obesity and with kids with vesicular ureteral reflux. But it could be idiopathic, and this is associated in African Americans with the ApoL1 gene. So often, what you have to do here is do a kidney biopsy. Now, how you're going to treat nephrotic syndrome? If you can, you treat the underlying cause and need a biopsy, usually to determine that. But you're going to use loop diuretics, and you may have to use a lot of them. Plus minus a drug like metalazone, which is a thiazide diuretic that's more potent, and that could help replete potassium. And you're going to give them statins, and you're going to careful VTE prophylaxis. And if they had a clot, they're going to need to be treated with anticoagulants, vitamin D supplementation, and vaccines. And, depending on what they have, it could go away on its own, or you could treat the underlying disease. If they have lupus, you can treat the lupus. If they have hepatitis C, that's a treatable disease now. If they have hepatitis B, it's a treatable disease. Hodgkin's, other cancers, you're going to treat them. If they have amyloid, that has its own treatment. Diabetics, you're going to have to work on the diabetic kidney with SGLT2 inhibitors, ARBs, and whatever. And with that, I'm going to stop. I'm going to give another talk on nephritic syndrome. Thank you.